Hi, today we'll talk about clinical immunological disorders. In this topic, we'll talk about six subtopics: hypersensitivity diseases, immunodeficiency diseases, autoimmune disorders, transplantation immunology, immunologic aspects of cancer, and immunization. These disorder encompass individuals who exhibit hypersensitivity to certain antigens, inadequate or unresponsiveness to microbial or other antigenic exposure, loss of mechanisms regulating the immune system from reaction against self. For the type 1 anaphylaxis, these reactions occur in genetically susceptible individuals who respond rapidly and excessively to the release of mediators, following complexing of an allergen to mast cell-bound IgE. When an allergen is reintroduced, it aggregates several cell-bound IgE molecules, causing membrane perturbations and degranulation of mast cells and basophils, releasing pharmacologically active agents systemically or locally atopy. For the first type of type 1 is the anaphylactic shock. This one is rapid, severe, generalized reaction that occurs when the allergen IgE complex induced mediators are released systemically. For example, the histamine and leukotrienes and TNF alpha, interleukin 1 and 6, and so on. These agents rapidly contract smooth muscles, increase the vascular permeability and secretion, and change the coagulability and induce hypotension, leading to multiple organ failure and death. The Hymenoptera venom, actually it's the bee venom, foods, drugs, and antibiotics like penicillin are common inducers and triggers of IgE. The second type is urticaria, hives, an IgE-mediated cutaneous form of immediate hypersensitivity characterized by vasodilation and increased vascular permeability of the skin. The histamine release is mainly responsible for the wheal and the flare lesion and the pruritus, which is the itchy skin. Asthma. Characterized by airway obstruction and acute respiratory distress caused by mucus secretion and constriction of the smooth muscles surrounding the bronchioles. Symptoms include wheezing, dyspnea, chest tightness, and cough. An influx of mast cells, CD4 cells, T helper 2 cells, basophils, and eosinophils result in cytokine release and inflammation. Important mediators are the leukotrienes, platelet activating factor, eosinophil chemotactic factor (ECF), and the histamine. The important triggers are respiratory infections, environmental pollutants, aspirin, and non-steroidal anti-inflammatory drugs. The chronic exposure to occupational or environmental and food allergens result in extrinsic asthma, whereas the intrinsic asthma can be induced by non-immunological means like cold and exercise. For allergic rhinitis, it is most common clinical expression of atopy, and it is as a result of inflammation of the mucous membranes of nose, leading to profuse rhinora, paroxysmal sneezing, nasal obstruction, itching, and the conjunctivitis, the hay fever. Allergens involved are pollen, fungal spores, house dust, and animal dander. Binding of the allergen to the cell-bound IgE release cytokine mediators including histamine, leukotrienes, prostaglandin D2, and ECF, eosinophil chemotactic factor. With certain allergens, a hyposensitive state can be achieved by repeated parenteral injection of the agent in subliminal doses. The desensitization is associated with an increase in IgG antibody, which combine avidly with the allergen in the circulation, thus blocking union of the cell-associated IgE and the mediator release. We'll talk about, for the second type of hypersensitivity, type 2, which is the cellular mid-antigen antibody cytotoxicity. And this occurs when an antibody is directed against epitopes that occur on the cellular surface membrane of organs and tissue, leading to the subsequent damage result from the osmotic or lytic action of activated complement, the opsonization by phagocytic cells or killing by the ADCC, the killing of the target cell by the TC lymphocyte, NK cells, or both. The destruction of the target cell results mainly from the release of peripherins and the serine proteases, which cause pore formation and osmotic lysis. For the first type of type 2 is occur in the transfusion reactions, which occur following the transfusion of blood containing RBC antigen foreign to the recipient. The ABO incompatibility reaction are most common. RH reactions are the most severe. The preformed antibody in the recipient agglutinate the donor's blood cells, resulting in complement-mediated RBC lysis or rapid phagocytosis. Fever is the most common reaction in severe reactions. Chest pain, hypotension, and disseminated intravascular coagulation may occur. Hemolytic disease of the newborn, second topic in type 2 hypersensitivity. It occurs following placental transfer of non-saline agglutinating maternal anti-RH IgG antibody, which binds to RHD positive fetal erythrocytes. The presence of these antibody in either the mother's circulation or on the infant cells can be detected by the COMS test, like what we have discussed in last lecture. Complement-mediated lysis or rapid phagocytosis follows, resulting in hemolysis and hemoglobinuria, which convert to toxic indirect bilirubin. The accumulation causes jaundice with respiratory and brain damage. When RH mother is injected with anti-RHD antibody within 1 or 2 days following delivery, prevent this disease. The anti-RHD antibody neutralizes the fatal RH antigen entering the mother's circulation following spillage during removal of the placenta, and prevents stimulation of the maternal immune system and injury to the future RH newborns. For the autoimmune reactions, type 2 as well, occur in genetically susceptible individuals who produce antibody against their own cellular membrane antigen by unknown mechanisms. Example is the Goodpasture syndromes, which is characterized by glomerulonephritis, GLN, and the pulmonary hemorrhage. The antigen is a glycoprotein dispersed on the glomerular basement membrane. Susceptible hosts produce IgG antibody which binds to the membrane antigen and activate complements, releasing the potent chemotactic factor C5a. The neutrophils are attracted to this antigen GBM complex where they release lysosomal enzymes, causing severe necrosis of the glomerular and loss of the filtration capacity. For the type 3 of hypersensitivity, it is the antigen-antibody complex reaction. It occurs when circulating antigen-antibody complex of a small size with antigen in slight excess escape phagocytosis and deposit in tissue or on the surface of blood vessels. These complexes cause damage by activating complement and releasing the chemotactic factor C5a, anaphylotoxins, and the clotting factors. Neutrophils are attracted to the area of deposition, releasing lysosomal enzymes that destroy tissues. Examples include the following. Arthur's reaction, which is rare inflammatory response to the intravascular antigen-antibody precipitates of intermediate size, occurring when highly sensitized human or animals are injected with antigen, leading to thrombi and hemorrhage and necrotic lesions. While serum sickness occurs following injection of foreign serum or its products, leading to systemic reaction with fever, pruritic rash, lymphadenopathy, and joint pains. A similar but milder reaction, allergic condition, can be provoked by drugs like sulfonamides and penicillin. Third example of type 3 hypersensitivity is a polyarthritis nodosa (PAN). It's characterized by continuous insult of the arterial walls by deposition of circulating antigen antibody complex, causing thrombosis and interruption of blood flow. Hepatitis B antibody complex are involved frequently. The fourth type is glomerulonephritis, characterized by soluble antigen antibody complex depositing on and behind the basement membrane of the kidney, causing an inflammatory response. The complexes can be detected with fluorescent antibody against either the antigen or the antibody or the complement. The antigen implicated most often are DNA, insulin, thyroglobulin, and the group A nephritogenec streptococci. Damage is due to the release of the lysosomal enzymes of polymorphonuclear leukocytes attracted by the chemotactic agent that destroy the glomeruli, resulting in loss of filtration. The next type of type 3 is systemic lupus erythematosus (SLE). It is a chronic inflammatory disease usually presenting in women aged 20 to 45. Its cause is unknown. The clinical pattern is associated mainly with arthritis. An ultraviolet light-induced skin rash, facial butterfly rash, pleurisy, pericarditis, vasculitis, rheumatoid factor can be present, and rheumatoid factor as well can be present. SLE is characterized by the formation of autoantibody to endogenous antigens, including RBC, white blood cells, etc., and double-stranded RNA. Double-stranded DNA and anti-double-stranded RNA and other circulating complex in a slight antigen excess lodge at random in the kidney, giving rise to the cardinal lesion of GLN. A lumpy-pumpy pattern of fluorescence distinguishes lupus GLN from the smooth pattern seen in the Masuji type of GLN, where the kidney antigen is dispersed uniformly. So the main difference between the cardinal lesion, the type which gives rise to the cardinal lesion, and the type which gives rise to the Masuji type, is that the antigen in the type of the cardinal lesion, the antigen is lodged at random location in the kidney, while in the Masuji type it is uniformly dispersed over the kidney. For rheumatoid arthritis, as a type 3 hypersensitivity, this is a chronic recurrent inflammatory disease initiated by unknown antigen that stimulates local antibody formation in synovium. Approximately 70% of patients possess the HLA-DR4 haplotype. Inflammation of the pannus and loss of cartilage characterize the joint lesions. The union of antigen with local antibodies alter the tertiary structure of antibody, so they reveal buried amino acid sequence which can be recognized as foreign, as an epitope by the immune system. These new epitopes stimulate the production of IgM, termed the rheumatoid factor, which react with the Fc domain of IgE molecules. As a consequence, the IgM-IgG complex which will be formed in the synovial fluid activate complement and release chemokines. The BMN are recruited and attracted, which while attempting to phagocytize the complex, they release lysosomal enzyme that destroy the articular cartilage. DTH cells, which T helper cells, the T helper cells involved in the delayed type hypersensitivity reactions, predominates and contributes to the damage, as do macrophage, which release interleukin 1 and 6 and TNF, as well osteoclast, which is a type of macrophage as well, emerge, which injure bones. The rheumatoid factor as one diagnostic sign can be detected by agglutination test employing IgG-coated latex particles added to the patient's serum. Rheumatoid arthritis is also classified as an autoimmune disease. For type 4, the basic lesion, the delayed type hypersensitivity, this is the basic lesion is an inflammatory response induced by activated macrophages, cytotoxic T lymphocyte and NK cells to intracellular dwelling microorganisms, as well as reactivity to small molecular chemical irritants. Here the antibody is not involved. The first one, the tuberculin skin test, is example in internal organs, example lungs. It identifies human beings exposed to or actively infected by Mycobacterium tuberculosis. The suspected patient is injected intradermally with an antigen extract of the tuberculosis. A lesion peaking in 1 or 2 days, resulting from the inflammatory response induced by the sensitized T cell action at the site of the antigen deposition. Skin lesion is initiated by Langerhans cells presentation of antigen to previously sensitized DTDH cells that have been recruited to the site of antigen deposition by chemokines. Subsequent APC and T cell secreted cytokines and chemokines attract BMN, followed by CD4 T cells. A non-specific perivascular accumulation of monocytes or macrophage cells results in the destruction of the organism's tissue or both. Granulomatous reaction occur if the microbial antigen persists in the tissue and continue to stimulate host reactivity. Interleukin 1 and 8 are released in response and attract an inflammatory cell influx. Interleukin 4 and interferon gamma promote the retention of the macrophage and cause the fusion of monocytes at the site, leading to an epithelioid cell granuloma, which derived from macrophage histiocytes and epithelioid cells. The next type is contact dermatitis. Can occur following deposition of small molecular weight chemicals like haptens or other irritant into the skin of a previously sensitized individual, causing a cell-mediated reaction. The haptenic agent becomes antigenic by combining with intradermal host proteins as carrier via the amino or the S grouping. Langerhans cells and endothelial cells serve as antigen-presenting cells. Subsequent re-exposure to the antigens result in chemokine and cytokine release, monocytic or macrophage infiltration, and a vasculating lesion and with erythema and induration. The common eliciting agent include nickel, dinitrochlorobenzene, rubber, poison ivy, and poison sumac, which is a kind of poison from a type of flower. Here you can see a table for the summary of the different types and the condition and the distinguished characteristic of each type. It's a good table showing the summary. And to conclude, here you can see for the hypersensitivity disease are conditions in which tissue damage is caused by the immune response. They may result from uncontrolled or excessive responses against foreign antigen or from a failure of self-tolerance, in which case they are called autoimmune disease. The two principal factors which determine the clinical and pathological consequence of such condition are type of the immune response elicited and the nature and the location of the inciting antigen. What the hypersensitivity reaction have in common? They have the first exposure to the antigen sensitizes lymphocyte. The subsequent exposure elicits a damaging reaction, while the response is specific to a particular antigen or cross-reacting substances. The hypersensitivity disease are classified on the basis of the effector mechanism responsible for the tissue injury. So we have, as we discussed, 4 types are commonly recognized. Type 1, it's a different type 1 which is immediate. Type 2 is antibody mediated. Type 3 is immune complex. And type 4 is a T cell mediated hypersensitivity. And from this table, it's another good table as a summary. It shows the different types and characterize the immune mechanism involved for each type and the mechanism of tissue injury as well. It's a good table to summarize all the mechanism of the different types and the mechanism of how the tissue got injury and the cells involved and the mechanism. The second topic in clinical immunological disorder is immunodeficiency diseases. These diseases occur during the prenatal period or early childhood. Depressed immune response is associated with the aging process. A child with a history of recurrent infections can be verified by decreased value of IgG, M, and A, or abnormal T cell, B cell, or CD4 CD8 ratios, as well as diminished response to standard vaccines in vivo. First type is the transient physiologic hypogammaglobulinemia. Occurs normally in 3 to 6 month infants. Although infants are born with adult levels of placentally transferred IgG, this level is diminished due to slow disappearance of maternal antibody, which has a half-life of around 22 to 28 days, the infant's early low rate of synthesis of secretable immunoglobulins. Okay, the second type of immunodeficiency disease is the X-linked A-gamma-globulinemia, Proton's disease. This is a sex-linked male disorder that affects 5 to 6 month infants. These patients present with recurrent pathogenic infections from streptococci, for example, and digestive tract disorder. The reactivity to viral infections appear normal, yet very few mature B cells are found. The defect is in the transition from the pre-B to the B cell stage in bone marrow. Absence of tonsils and germinal centers and B cells and antibody is diagnostic. Treatment involves a transfer of adult serum immunoglobulin to diminish infections. The third type is dysgammaglobulinemia. Describes an immunoglobulin deficiency where the patient has decreased level of a selective immunoglobulin class, usually IgA. Mucosal surface protection is diminished or lost. Although the number of IgA bearing cells is normal, they fail to differentiate into secreting plasma cells. An increased susceptibility to autoimmune disease is seen. The congenital thymic aplasia, it's a kind of syndrome called the George syndrome. Patients exhibits poorly developed or absent thymus and parathyroid glands, resulting in depressed cell-mediated immunity. Infections caused by opportunistic organisms like Candida and pneumocystis and viruses. This disorder is not hereditary but is caused by unknown intrauterine injury to the third and fourth pharyngeal pouches that occur during the 12th week of gestation. The germinal centers, plasma cells, and serum immunoglobulins appear normal. The absence of parathyroid glands results in hypocalcemia and tetany, spasms. Vaccination with live vaccines, for example like measles, is contradicted. Fifth type is a mucocutaneous candidiasis, highly specific T cell disorder that is characterized by an absence of immunity to candida. Patients have apparently normal number and function of T and B cells. Approximately 50% of patients have endocrine dysfunction like hypothyroidism. Sixth type is Wiskott-Aldrich syndrome. It's a sex-linked male disorder occurring mainly in children. It features thrombocytopenia, eczema, and recurrent infections. A poor response to bacterial capsular polysaccharide agent is seen, leads to increased incidence of lymphoreticular malignancy or lymphomas may occur. As well, depressed cell-mediated immunity and low serum IgM, but IgG and IgA levels appear normal. The primary defect is on the short arm of the X chromosome and may result in an absence of a specific glycoprotein receptor on cells and platelets. 7 type is a SCID, severe combined immunodeficiency disease. It's a rare disorder. It's a genetic defect in the stem cells, absence of thymus gland and the T and B cells. Affected children are extremely susceptible to infection and have a very short lifespan. Deficiency as well, they face deficiency in adenosine deaminase, 50% of the patient. There is accumulation of toxic deoxyadenosine triphosphate, which inhibit ribonucleotide reductase and as well prevent DNA synthesis. A mutation in the gamma chain of interleukin 2 receptor gene is found in other patients with SCID. For chronic granulomatous disease, results from a genetic defect in the NADPH oxidase system in neutrophils. Patients are susceptible to infection by age 2 years, especially to organisms of low virulence. Neutrophil bactericidal activity is defective due to depressed NADPH oxidase, superoxide dismutase activity, and decreased hydrogen peroxide levels. The diagnosis is based on failure of neutrophils and macrophages to reduce a nitroblue tetrazonium dye. Usually the treatment is with interferon gamma has been successful. The next type of immunodeficiency disease is the AIDS. It is caused by, of course, the human immunodeficiency virus HIV, whose major target is CD4 T helper cell, leading to its lysis. As well, macrophage and astrocytes and dendritic cells with much lower membrane levels of CD4 can be infected as well. Depletion of the T helper cell population results in loss of cytokines and the capacity to activate other immunocompetent cells. Consequently, infection by endogenous and nosocomial agents predominates. Common organisms include a lot of factors, including viruses, pneumocystis, CMV, toxoplasmoma, and etc., mycobacteria, etc. To detect it, it is used to detect this virus. Commonly used the indirect ELISA test detects the antibody HIV in the patient's serum, which can be confirmed by Western blotting, as we discussed in the lecture of the immunologic assay. The last type in immunodeficiency disease, functional deficiency, is a general factor or any functional deficiency in any of the many cytokines and chemokines or other receptor could contribute to the immunodeficient state. Going back to the structure of the immuno and the component of the HIV, we can see that the virus consists of envelope formed from glycoprotein like GP120 and GP41 that houses several core proteins. The virus has several genes that code for enzymes, example the integrase, reverse transcriptase, and the protease. All of these enzymes play a major role in integrating the viral DNA into the host genome. The HIV binds to the CD4 receptor on T cell and the obligate chemokine receptors via, as you can see from the figure, via GP120, while the membrane fusion and the entry of the virus through the cell membrane is mediated by the highlighted GP41. A viral two enzyme, important enzyme is the viral reverse transcriptase, transcribe the viral DNA, the viral RNA into DNA, and its integration into the target cell genome is facilitated by an integrase, as shown in the figure. Following activation of the infected T cell by other viruses or antigen, now the provirus is transcribed, translated into viral protein, assembled and replicated, leading to the lysis of the host cell. Thank you.